Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. I was fortunate enough in 2006 to be the principal investigator on a 6-month LHRH injection that was sub-Q that resulted in the approval of the drug. There was really a slow adaptation of longer-acting LHRH compounds, and in 2015 we published an updated overview of sub-Q LHRH compound. Joining me today is Dr. Tim Langford from Little Rock, Arkansas, Dr. Dan Salzman from San Antonio, Texas, and our moderator is Dr. Richard Harris from Chicago. They're going to talk about the effect of COVID-19, telemedicine, and so forth on length of LHRH injections. Richard?
All right, well, thank you very much, David. So, as we all know, there are multiple different companies that make agonist and antagonist, and we, as I said, have both antagonist and agonist. Some of these preparations can go from 1 month, 3 months, 4 months, and 6 months. There used to be yearly applications, but those have seemed to have fallen by the wayside. In this day and age, of course, the COVID epidemic has really changed a lot of the way we practice medicine. So the first question I would ask is to Tim about, in Arkansas, are you still giving 6-month injections? Are you bringing people in at 3 months or 4 months? Or how has this COVID epidemic affected you in the way that you're seeing patients?
Sure, Richard, I appreciate that. And as LUGPA president, I really appreciate what LUGPA does with independent practices, because I think by independent practices by nature have to be, I think two things come to mind: resilient and adaptable. You know, we're dealing with new regulations and technology and data and telehealth. I think it's in our DNA, and I think organizations like LUGPA do help us prepare to adapt to the needs of our patients. And in Arkansas, we're not staying shelter, but we have a lot of advanced prostate cancer patients. Probably we have moved from 6-month injections primarily over the last couple of years of our advanced prostate cancer clinic to more 3-month of leuprolide injections, and we still have 20% of patients getting degarelix. These are mainly patients with metastatic disease and getting their monthly Xgeva. The way this has affected us, I mean, our nurses very quickly adapted to how can we keep these advanced prostate cancer patients out of our building, keep them safe. So we actually have a drive-through lab. So they come through, and it's a 5-minute deal. They come through and get their lab, and we also have a drive-through injection site in our parking lot. Our parking lot's pretty empty right now, and we have a little shelter so they can come by and get their injections. So we're moving now from the 1-month injections mainly to 3-month, and we're actually doing 6-month again. That always makes me nervous because it seems like we do a better job of getting the PSAs and the testosterones in the lab every 3 months. But that's what's going on in Arkansas right now at our practice.
So, Dan, let me ask you, there's clearly patients should be on 6 months, and clearly patients who should be on 4 months or 3 months. Of course, you could put people on 6 months, and I know in the world, and you're big on, CRPC world, as am I. We have kind of moved the needle to see people at a much more frequent interval, just because there are so many new amazing therapies out there, and we have the options to change. How have you managed these patients in the CRPC world? Have you put them on 6 months and seen them more frequently, or put them on shorter? So let me know what you're doing in San Antonio.
Well, Richard, again, I want to echo what Tim says. It's great to be a member of LUGPA and all the things that LUGPA brings. It's interesting over time. I've become a bigger fan of an antagonist. One, because I think there's less cardiotoxicity. I don't have to worry about mini flares. And I've been combining a lot of my bone health, meaning Xgeva, which is already on a monthly basis. So we do a lot of the antagonists, which unfortunately at this time its rate limiting step is that it's a 1-month formulation. With COVID-19, we are looking to also do more of the 6-month depot formulation. But in a patient that's coming in for monthly Xgeva, that makes it a little bit more complicated. In certain cases, I think we've actually said we'll hold off on the Xgeva and then watch them as is. We have not gone to the extremes of having drive-by labs and drive-by injections, but we are doing, following social distancing, wearing masks, taking temperatures, doing all the things that are appropriate to ensure patient safety and our employees' safety. But it's a challenging patient population because they need frequent visits. They could be progressing in a short period of time. So I don't know what the correct answer is, but we have not shifted a lot to the longer acting, agents, agonists at this point in time.
So I guess one could paraphrase that by saying that regardless of what formulation you use, the people who are in the CRPC space, or for that matter in the hormone-sensitive metastatic prostate cancer space, which we all know now involves double drug therapy with ADT and a novel hormonal agent, or at least it should if it isn't, that both of these groups of patients really need to be seen in a more timely fashion than we've seen them in the old days. I mean, Tim, would you agree with that statement?
Absolutely. Richard, I couldn't agree more. That's one reason we did go from the 6-month injections to the 3-month for that reason, to make sure we saw these patients in a timely manner. It seems like if we put them out for 6-month injections, we might miss that opportunity there. And that's important when you're talking about M0 patients or becoming castrate resistant and catching them early to get the appropriate therapy at the right time.
Dan, your thoughts on that also?
Yeah, I couldn't agree more. I mean, I think we all have been on guidelines committees and with radar, and you felt like the minimal you should be seeing these folks is every 3 months. Well, if you start somebody on a novel hormonal agent in addition to ADT, you're probably going to see them a lot sooner than that. And it requires a little more frequent lab monitoring and adjusting and, side effect profiles. So I completely agree that this is, in COVID-19, this is a very challenging patient population to not at least get labs and monitor. We have set up telehealth, and we're doing a lot of it after they get their labs and injection. But I'm sure everybody on this phone call will attest to having an 85-year-old on the phone doing telehealth is extremely challenging. So,
absolutely. So, Tim, I think that you would concur then that these patients really would have to fall into the urgent, emergent type of category, where it really should necessitate them being seen in the office. I mean, I wish we could give injections over telehealth, but we haven't figured out how to do that yet. But I think you would agree that it is imperative that these are classified in that scenario and they do come in for the injection. I know that there's various ways to do it, so you could give an injection and then have the patient go home and have them visit on telehealth. But as far as getting them in, don't you agree that that is imperative that every group around the country still make sure that these are a special class of patients who have to be seen?
Absolutely, Richard. We're down to probably 25% of the normal visits we would do in a month, but a lot of these are advanced practice cancer patients. I mean, you put someone, an 80-year-old gentleman, on one of these novel anti-androgen drugs, and they need, they may have profound fatigue or all sorts of electrolyte problems, and those need to be managed on a not 3-month, not 6-month, but on a monthly basis. So I couldn't agree more. We're doing a lot of we're pushing out patient visits, but we are doing a telehealth for all of these reasons we just mentioned.
Great. Well, listen, guys, thanks a lot for sharing your feelings about this. It's, clearly, I think that when you're dealing with a patient who is being seen more frequently, and that we know that your practices, you're doing a lot of the a lot of the advanced prostate cancer clinics and taking care of men with metastatic castrate-resistant disease in other states, that it's important to keep a close eye on them, and you sort of parallel your LHRH injections to those visits. So again, thanks, and I hope you all have a great day. Appreciate it.
Thank you.
All right, thank you, David.